renal colic as well as ureteric colic. Ureteric colic, it is mainly, or renal colic, it can be due to calculi or stones. You can see these X-rays. This you can see the stones. This is the pelvic X-ray. You can see the stones, these white colored stones here. And this is another picture showing the stones in the ureter, in the bladder, or in the pelvis. So different type of stones which will block the way, and it will cause inflammation here, and that causes the severe pain. If it's in the ureter, it will be of severe pain. And usually this ureteric pain, it will be of sudden onset and it will be severe, and there may be hematuria also. And when you take the X-ray or ultrasound, we will see the calculi. And we will come to the treatment. Can you tell me the treatment? What treatment we can give? So we have to, we have to reduce the pain. So painkiller, what is a painkiller or analgesic? You know?
Paracetamol.
Paracetamol is okay, but it is a severe pain. So some strong analgesics.
Diclofenac.
Yes, diclofenac, analgesic. Some people, they use morphine also, but don't go for that much and severe analgesic. Strong analgesic. You can go for diclofenac. And because there is spasm, some antispasmodic also has to be given. Antispasmodic, like anticholinergic drug, we have to give. So that is why I have written this dicyclomine. It is an anticholinergic drug, and this oxybutynin also, it is an anticholinergic drug. Dicyclomine, it acts on the M1 receptors. This is M1 as well as M3. So it is anticholinergic and it causes relaxation. Then that is antispasmodic. Spasm will be removed. Then what is tamsulosin? Tamsulosin? Yes. What is tamsulosin? Anyone? I don't know.
Alpha blocker.
What is it?
Alpha blocker.
Oh, yes, it is alpha-1 selective. It is a uroselective alpha-1 blocker. Uroselective means it is selective for the urinary bladder as well as ureter, especially urinary bladder. So it is an alpha-1 selective, alpha-1 blocker. It is uroselective. So that is tamsulosin. This is again causes the relaxation. Then as he was telling, diclofenac. So these are the 3 drugs that will be given, and we have to give plenty of oral fluids. And we have to see the pain, whether it is relieved or not. And if the ureteric stone is more than 6 millimeter, we have to do some surgical intervention. So there are different types of surgical intervention. Lithotripsy is there, lithotomy is there. So one lithotripsy, this is the lithotripsy is extracorporeal shockwave lithotripsy. That means using high sound waves. This stones will be broken, and it will then, if it is broken down, it will come out very easily. So suppose there is a stone here, through sound waves it will be broken, and if it is less than 4 millimeter, it will come out through the urethra. So that is the technique, that is extracorporeal. So here there is not an invasive technique. It is extracorporeal. It is outside. So it is something good, but if it is very large, means it is very difficult. Such cases we have to go for lithotomy, lithotripsy, that is transurethral lithotripsy. Like this, we can go and break the stones, or lithotomy, that is open, abdomen open, and so different techniques are there. So we have to do the surgical intervention. Okay, now you can write down the prescription, acute ureteric colic, in your book. And when you come to college, when you go to college, not come to college, you can write it in your record. Please write it down. Hello. Shifa TC, are you all writing now?
Yes, ma'am.
Okay, please. Over? Niswa, is it over or still writing?
Yes, ma'am.
Over.
Yes, ma'am, over.
Okay.
No, ma'am.
Oh, okay. Okay, then please write. I think it's time to finish it. Is it over now?
Yes, yes.
Yes. Okay. So now we will see another prescription, that is migraine. Okay. So can you tell me some drugs for migraine? Whom should I? Gilan Miriam, are you there? Gilan. Gilan.
Ma'am.
Yes,
Yes,
you are.
ma'am.
Okay. Tell me one drug for migraine. Any drug. What is migraine? What is a symptom?
Headache.
Headache. So headache means something to remove to relieve headache. What drug you can give?
You.
Hmm? Yes, tell me.
If you.
Yes. If you have a head, if tell me.
Paracetamol.
Paracetamol. Okay, that's fine. If it is mild headache, paracetamol will be okay. Or if it is severe, means we have to go for still stronger one. Paracetamol is fine. We can start with paracetamol. So one of the drug is paracetamol. Any other drug? Can anyone mention any other drug for migraine? Hmm?
Ergot.
Yeah. Yes, yes, very good. It was who told? Shifa.
Yes, ma'am.
Yes. Okay. Very good. Okay. Now we will see anyway. So this migraine, as you know, sorry. So there are different types of headaches. That is, it can be of, I'm talking about different types of headaches, not migraine. It can be due to sinusitis. But usually it will be behind this frontal bone or the maxillary, this bone. That is sinusitis headache. Then cluster headache. It will be, usually it will be in and around one eye. Tension headache, maybe after some exams or others, tensions. It will be like a band squeezing the head. So that is tension headache. Whereas migraine, it will usually, the classical migraine, it will be unilateral on one side. Severe pain, and it will be associated with nausea and also aura. Aura means it's something, some visual or auditory, some changes that will happen just before developing this headache. That is called aura. So usually there are two types of migraine with aura and without aura. So some people without developing in aura, they will be developing a headache. So that is both are migraine only. What causes migraine is actually there will be cortical depression, and in the brain there will be cortical depression, and that will causes the permeability of blood-brain barrier, and that can cause vasodilatation. And this vasodilatation, because when the vessels are dilated, meningeal vessels are dilated, it can cause pain. And in addition, this dilatation will cause irritation of the trigeminal nerve terminals, that is perivascular. So all these things together, it causes this headache. So meningeal vessel dilatation. So the drugs that are used are actually to reduce the vasodilatation, or that causes vasoconstriction. And also analgesic, because of the inflammation, there will be another thing, there will be some other vasoactive peptides are also liberated at the site of this vasodilatation, and that also causes inflammation, and this will add to the pain. So we have to have some drugs that will cause vasoconstriction and also anti-inflammatory as well as analgesic. And there is also calcitonin related gene peptide. So this CGRP is also one factor responsible for the inflammation of vessels and causing a headache. And there are certain drugs that will inhibit the CGRP also. So this is about migraine. I think in class already it would have discussed. I don't know who has taken the class. So we will see the treatment. Sumatriptan, it is a triptan. And this also, it is a 5-HT1 BD agonist, and that causes vasoconstriction. So there is vasodilatation. We have to give produce vasoconstriction. Then ergotamine, one Shifa was telling, it is ergotamine. This also causes vasoconstriction. Then caffeine also vasoconstriction. Paracetamol, it is an analgesic. And this ergotamine and other drugs, especially ergotamine, it can cause nausea, vomiting also. In addition, migrainous people, they will be having vomiting. So we have to give domperidone. It is an antiemetic drug. So these are the drugs: sumatriptan, domperidone, ergotamine, caffeine, and paracetamol. So to start with mild cases, we can just go for paracetamol. And if it is not relieved, one by one you have to add. So that is the treatment of migraine. And chronic migraine, we can give amitriptyline. This is a tricyclic antidepressant, 25 milligram. So like that, we can treat. And the prophylaxis, everything you have already studied. So now you can write down the prescription for migraine. Please write sumatriptan. So 25 milligram BD. Then domperidone, it is an antiemetic, 10 milligram BD. Ergotamine, 1 milligram starch. If needed, it is repeated. Caffeine, 100 milligram. And paracetamol, 650 milligram, 3 times daily. Chronic migraine, it is 25 milligram. Noora Bashir is present today. Noora Bashir?
Yes, ma'am.
Yes, yes. Okay, okay. So, finish writing? Hello? Have you finished writing? No
Yes,
one.
ma'am.
Okay. Or Akhil Shiros, have you finished?
Yes, ma'am. Yes.
Okay. So now we will go to the next prescription, that is acute bronchial asthma. So acute bronchial asthma, what is a drug? Bronchial asthma. Yes, whom should I ask? 1 minute. Jaffna. Jaffna, are you there? Jaffna?
Yes, ma'am.
Huh? Many Jaffnas are there. Several yes, madams are there. Jaffna. Yes. Several yes, madams. Okay. So what is a drug for this bronchial asthma? Can you mention drugs? So please tell your family members to go out of the room. Please ask them to move out of the room. Okay, now Jaffna, tell me.
Ma'am,
One drug for bronchial asthma. What is it? Yes, tell me.
salbutamol.
Salbutamol. How will you give salbutamol? Acute bronchial asthma. How will you give?
Inhaler.
Inhaler therapy. Okay, okay, okay. Very good. Then, okay, you can Aisha Khatun. Aisha Khatun. Aisha. Aisha Khatun. Aisha Khatun. Aisha Khatun, are you there? She left. When I called, she left. Aisha Khatun. You are not there? Aisha Khatun, are you there? Okay, you are not there. Sahila Najam. Najam. Oh, what is that full name? It is not saying. Sahila.
Yes, ma'am. Yes, ma'am.
Sahila Najam. Ah, yes, correct. Sahila Najam. Can you, one drug she told that is salbutamol. Any other drug for bronchial asthma?
Terbutaline.
Okay. Any that is another beta 2 agonist. Any other group? Any other group for bronchial asthma? Okay, no problem. Irene Davis. Any other drug for bronchial asthma? Irene Davis.
Yes, ma'am.
Can you tell me one drug for bronchial asthma? Salbutamol, terbutaline, already over. Any other drug?
Ipratropium bromide.
Oh, okay, very good. Ipratropium bromide. Shibin NB. Any other drug? Shibin NB.
Yes, ma'am.
Any other drug? Salbutamol, terbutaline, ipratropium bromide. Any other drug for
Montelukast.
Montelukast. Okay, very good. Then Aisha Khatun, have you come back? Aisha Khatun.
Hello. Yes, ma'am.
Okay. So tell me one another drug, Aisha Khatun. Hello.
Migrain.
What?
Hello.
Okay. Okay, please don't
Hello,
respond.
can you hear, ma'am?
Yes, yes.
Hello?
Now, yes, I can hear you. You tell me one drug for bronchial asthma.
Hello.
Yes, I can hear you. Already.
Hello.
Yes, I can hear you.
Hello, ma'am.
I can hear you, Aisha. Okay, no problem. You be there. Aisha Hiba. Aisha Hiba.
Yes, ma'am.
Tell me one drug for bronchial asthma. Salbutamol, terbutaline, ipratropium. Over. Any other drug? And also Montelukast over. Any other drug? Go fast. The most important drug. No one is answering the most important drug. Which is the most important drug? Who can answer the most?
Prednisolone, ma'am. Prednisolone.
Yes, corticosteroids. Corticosteroids. Okay, then we will see the slides. So that is acute bronchial asthma. So we have to the rapidly acting wait, 1 minute. The rapid acting drug, it is actually salbutamol. So we will be giving inhalation, that is a meter dose inhaler, and we have to give 100 micrograms. This is acute bronchial asthma. 2 puffs every 30 minutes until symptoms subside. That is the number 1. Then prednisolone, in the severe cases, we can give 20 milligram BD for 5 days. This is only short course therapy. So there is no chance of developing Cushing syndrome or anything. And we have to taper off the doses gradually also. Then as you told, Montelukast, it is a leukotriene antagonist, 4 milligram OD for 1 month. Salbutamol, we have giving inhalation. In addition, we are giving tablets also, BD for 5 days. Then ranitidine, because we are giving prednisolone, it may cause some gastric irritation. So along with that, we have to give ranitidine or other PPA or anything. For 5 days, we have to give. Then we have to review after 1 week. So the most important drug, it is salbutamol inhalation and prednisolone. So inhalation, I have given only one type of inhaler. There are combinations also is there, that is this salmeterol and fluticasone or budesonide. Combinations are there. That inhaler also is possible. we can use that. Then prednisolone tablet will not be needed. If it is severe means we can add. Okay, now you can write down the prescription, acute bronchial asthma. Yeah, finished writing means please tell me it is over. Someone please respond. Over? Irene Davis, is it over?
Yes, ma'am.
Okay, I think all are written. So we will go to the next. This is status asthmaticus. So it is the severe type of asthma, continuous breathlessness. So that is status asthmaticus. So again, this is a very emergency situation. We have to admit the patient and we have to give nasal oxygen, 60% high flow rate we have to give. Then the drug again, it is the salbutamol nebulization, or it can be a combination of salbutamol and steroid also. So you know what is a nebulizer. I think in our department, Ravi sir would have shown you all these devices, isn't it? Yes or no? Hello, please respond. Have you seen all the devices? Metadose?
No, ma'am.
No. No. You're telling no? Okay.
Ma'am, metadose inhaler, sir has brought in the class. Those things. Medicine, sir.
Rotahaler, all those things.
Yes.
But
Yes.
nebulizer he has not shown.
Yes, ma'am.
Okay. So I'll ask him to show that because it is in the department. Okay. Oh, okay. Department means it is okay. It may not be easy. We have to. It is like this only, same thing. So there will be. It's an apparatus like this. So here, and there is a mask here, face mask, and here we will be pouring the drug, and it will be connected to the power, and it will be vaporized, and this here the vapors will come, and it will be inhaled by the patient. So here this is a for emergency purposes we have to go for nebulization. So those who are having bronchial asthma, they prefer this nebulization rather than metadose inhaler. Metadose inhaler means this it's a coordination. It is little more difficult when they are having severe breathlessness. So, but if you are keeping a mask and keeping nebulized, it is more comfortable. So we have to give nasal oxygen, nebulization with salbutamol, and hydrocortisone we have to give. It is a corticosteroid. IV start followed by 100 milligram IV 8 hourly. Then ipratropium bromide also, it is an anticholinergic drug. Again, it is a puff, that is metadose inhaler. Then monitor the oxygen saturation and respiratory rate. If there is chest infection, we have to treat with antibiotics. So best antibiotic will be ceftriaxone, 1 gram IV for 5 days. Then because of this severe breathlessness, there will be a lot of dehydration. So that has to be corrected with saline. And also acidosis has to be corrected with sodium bicarbonate, and he has to be seen after 3 days. So the patient has to be admitted. It can be given as OP also, but it has to be under observation in the OP department and give nebulization. Okay, you can write down the description. Status asthmaticus. Have you finished writing? Okay. Can you finish writing? You please tell me. Ashwini, Sunil, are you there?
Yes, ma'am.
Okay. Okay, just verifying. Sumaya Rashid, are you there? Sumaya Rashid, are you there? Hello. Sumaya Rashid, are you there?
Yes, ma'am.
Yes. Okay. Okay then. Have you finished writing?
No, ma'am.
Okay. Please do it first.